and welcome to the FEELS COVID-19 seminar. I'm going to hand you over to Kumar Murthy, our director and task force member, who's going to welcome our presenters today. Thank you.
Okay, thanks, Sarah. So good day to everybody. You see the wonderful world of online communication. It's both private and public at the same time. But anyway, good day to you wherever you are. I understand that's the correct way to greet people because it might be morning, evening, or afternoon or some other time where you are. I hope you're all keeping well. I'm really happy that today we're going to have Jianhong Wu and his group, including Zachery, who will be presenting on their work on quantifying the shift in social contact patterns in response to non-pharmaceutical interventions. Many of you know Jianhong and the work of his group very well. He is a very leading personality in the field of infectious disease modeling, the mathematical modeling. He is the scientific lead on our current field CHR, CRM, PIMS, ARMS task force. And he also leads a CCAM lab on the mathematics of public health. So a very important contributor to the subject, both in general and at the Fields Institute. So Jianhong, welcome to the seminar, and please present your work.
Thank you, Kumar, and thank you for the kind word, and thank you for the opportunity to allow a sub-node of the National Task Force on COVID-19 mathematics, the laboratory of the Industry and Applied Mathematics, or LIAM, allowing this research group to present some of our research results today. The LIAM has been collaborating with public health agencies and the vaccine industry, and has the really privilege of support from the fields to establish and host the Laboratory of Mathematics for Public Health. The current research group at the LIAM has been very lucky to include a large number of postdocs and a PhD student. It was possible due to the support from a number of public health agencies and the partner industries, including the Fields Institute. And this group was actually assembled before the COVID-19 pandemic, but our funding partners have been very generous to allow this group to redirect our research focus to COVID-19 study since earlier February. So we've been really conducting policy-driven research in the last few months in many areas, including nearcasting, forecasting of the epidemic trends, evaluate interventions, assess population risk, and design optimal reopen strategies. I am quite frankly very proud of this achievement. I say so, not because I'm directing to that, but really because all this work have been done by our trainees, by the postdocs and the PhD students. As many other senior collaborators of this group, including Kumar and Nick Ogden. And I think it's fair to say we have been playing real rules that just to encourage them, facilitate them, and challenge them. So today is another challenge for one of the PhD students, McCarthy, to present his work on behalf of the whole team. So Zach, somewhere pleased to have you. Thank you.
Thank you so much. And thank you for your kind introduction, Professor Wu. So hello and welcome everyone. So I'll be speaking about shifting contact patterns and how this shift occurs in response to different interventions. So as Professor Wu had mentioned, there's a number of people that are on our team and great people behind this work. So I just happen to be the one speaking in front of you today. So I'll be presenting work that is not yet in print, but is this article here, accepted in Journal of Mathematics and Industry. So I should note that so the collaborators for this particular project, so including Professor Kumar, Nick Ogden as well. And so our Liam recovery group on the right here. So I'd like to take a special thanks to the COVID task force here. So COVID-19 in Canada needs no introduction. COVID-19 needs no introduction. So on the right, we'll see the confirmed and probable cases in Canada according to province. So this was taken a few days ago, so case is not up to date exactly. But the sense is that in response to the pandemic, different interventions, so non-pharmaceutical interventions, have been implemented to mitigate or to suppress transmission in an effort to limit the burden of disease. So these interventions are in the form of community-based measures. So for instance, these closures and limiting the size of gatherings, and also occur as more personal or individual measures. So these would be in the form of masking, so the utilization of masks and more hygienic measures. So while different measures have been put in place, what extent do these alter the way that the community mixes with one another? And how effective are these interventions in reducing contact between individuals? And the reason that we're asking this question is because we can use this mixing in both a retroactive way, so looking in the past, and proactively in the future. So the heart of this work aims to address this technical question. And here we'll focus on community-based measures. So a brief outline, really to address this question about contact mixing in the presence of measures, we develop a more general framework. And this framework allows us to incorporate age structure. And within this age structure, we embed several key really features. So these are the age-specific susceptibility to infection, the mixing in different locations. So in this work, we look in the household, workplace, school, and community settings. And we also assess the transmission acquired in these settings. So I should note that the work we present is quite general. However, we're showing work that was done applied to Ontario-specific data, but this approach is general. So on the right, we'll see the confirmed cases in Ontario up until about mid-May. And we chose this as a study period because starting May 19th, there was a staged reopening. And May 16th, we started easing measures, so in the province. So we chose to analyze the escalation phase of the epidemic here. And in particular, the specific measures that were put in place during this period, we break up into 4 specific phases. So first phase, so our phase 0, monitoring and travel advisories. Then we closed public school system and the state of emergency and more distancing advisories, hygienic measures, these were put in place. And then finally, on March 24th, we had a non-essential workplace closure. So this was the major intervention. So the strategy for how we confront our research problem is we introduce a transmission model. So this would be the heart of our study. And so then we have 2 questions, really key questions. How do different age classes mix with other age classes in Ontario? And the other element is, how do we capture these interventions with our transmission model? And the way we do this is we absorb the interventions into the contact matrix, which will be phase dependent. So we look at the heart of our work here, which is a transmission model. We go into the transmission model. And on the right here, we have a diagram. And I would just like to briefly mention, so not to get into too much of the detail, but the sense is that individuals who are susceptible may be exposed to the virus. Those that are exposed and not identified through contact tracing may either remain asymptomatic and recover, or they will develop symptoms and become diagnosed due to these symptoms. Also, individuals may be identified through contact tracing and then diagnosed. And the reason we have two copies of these same structure is because we have the interactions with age class I and the age class J. And I should note that in this model, the asymptomatic and the symptomatic, these are infectious. So again, we feature 6 age classes in this model. So these are 0 to 5, 6 to 13, 14, 17, 18 to 24, 25 to 64, and 65 and above. So the reason we choose these age classes, because this is representative of, say, daycare ages, school age, high school age, university age, maybe young adults, the workforce, and also the senior age class. And on the left, you'll see the form of the model equations. So this is a system of ordinary differential equations. Sorry about that. Now we have our transmission model, our age structure model, and now a contact matrix for Ontario will be required. And in prior work, it was addressed how different age classes interact with different ages in terms of contacts that are relevant for the spread of respiratory illnesses. So this is part of the famous polymod study. This is reference 4 at the bottom of your slide. And later on, using information specific to Canada, these polymod contact matrices were projected to Canada. So we have the mixing matrices for the household, the workplace, the school setting, other locations, and finally the sum of all settings. And we will augment these matrices to model the mixing in Ontario. And the way we do this, we apply a series of transformations using demographic data in Ontario. So a few of the technical requirements for our transform is that we have 6 age classes for our contact matrix. Also, contacts must be reciprocal. So this conservation law must be satisfied. Similarly, we must account for the Ontario demographic. So the demographic profile of Ontario may be different than Canada. And lastly, the contact rate is adequately altered. So we have our contact matrices as a result of our transformation. And I should note these are the contact mixing in Ontario in the absence of physical distancing measures or more measures. And we have the household, workplace, school, community, and all settings combined matrix. And so at the bottom of your slide, reference 6, we use some of the machinery that's posed in this work to, as well as our own machinery, to construct this transform, to build the matrices. And briefly, the way to read these contact matrices. So the rows represent the contactors and the columns represent the contactees. So I contacts J. So good, we're making progress. And we have the mixing in terms of mixing without interventions put in place. But we wish to capture the effects of the non-pharmaceutical interventions. So we use our baseline matrices as building blocks. And the sense is we will build in the public health interventions into the contact matrix, and we'll use a time-dependent contact matrix with 4 phases to accomplish this. So the layout here in phase 0, so with our baseline matrices, our household, workplace, community, and school setting matrices, so which we denote by CH, CW, CC, CS, so these are matrices. We model these interventions into the contact. So in phase 0, we assume that the baseline matrices represent the mixing. So monitoring international travel advisories. So no major interventions at this stage to alter the contact. In phase 1, we close the schools, and we assume there's an increase in the community contact. So we introduce this weight associated with the community contact matrix. And similarly, we have a shift to the household contact. In the very same way, for phase 2, our state of emergency declaration and other advisories, we reduce some of the community contact and shift again to the household. Now in phase 3, this was so we actually model this as time dependent to capture the society's adherence to more strict measures. And so this model equation represents an exponential decline in the community contact, the workplace contact, with a shift to the household contact. So here is our contact mixing. Now all the ingredients are in place, and we're ready to fit our mathematical model. So we use our age-stratified case data to parameterize the model. And so within the model fitting procedure, the weights that were introduced previously associated with the contact matrix are estimated. Now, we fit the model to cumulative reported cases in Ontario, and we fit to 6 line lists. So 6 lists of time series, all in a single fit. So in this sense, I mean that all 4 phases of the epidemic, so up until May 16th, are fit. And here on our graph, the red dots represent the model, the data points that we fit the model to, and the blue dots are not fit to. So these are included as an illustration, because notice that the final age class here, the senior age class, follows the expected trajectory of the model fit, whereas the younger age classes do not. So they're increasing. And just like to note that this may be due to different, potentially due to mixing within these younger classes. And we had, so those familiar with the situation in Ontario, we had a warm, nice weather weekend. I believe it was Mother's Day. So we may have had increased mixing in the younger age classes. And also, lastly, to address noise in this reported case data, we quantify uncertainty by assuming the new cases follow a Poisson distribution, and we refit the model to 1,000 realizations of this data. So we now have a parameterized model. And before unpacking the results, I would just like to note that we're speaking about the interventions and their effectiveness, but I'd like to be clear that the interventions were estimated to be effective in reducing transmission. So this is the RT, and we see the RT decline below 1 in early or mid-April. And the method, so we compute RT using our model, so the transmission model previously and the next generation method. So now to unpack our model fit. So recall we identified parameters associated with the contact matrices, and this allows us, in fact, to estimate the mixing profile in each phase. So we see the mixing profile for Ontario in phase 0, phase 1, phase 2, and phase 3. And what we notice is that the household contact pattern emerges as the measures become stricter. And this is in agreement with prior work where actually studies conduct more survey-based approaches to see how individuals contact age classes of different individuals. So these are more participant-based contact surveys. And these studies observe similar results. And to further unpack our model fitting, so we have the contact matrices. Now using the mean connectivity, we call it. So if we have a contact matrix C with age classes, the population of age class I as NI, then we can compute the average number of contacts in this population. And so we compute, so on the left here, we compute the contact in each location. So we have the household contact, the workplace contact, community contact, and school contact. And so we do this in each phase. And notice in our final phase, we have the exponential decline of the workplace and the community contact, and the household contact does not change much. So we see this dominance of the household contact. So we also have a numerical way to interpret these same, essentially this graph. And so just like to point out the contact mixing in the school, about 1.5 per day. So this is the lowest setting. And so the total contact in phase 0 or pre-interventions, pre-major interventions, about 12, which later declines phase 3 to about 6.5. And we'd just like to note the distribution of this contact. So we have major decrease in the workplace and the community contact with an increase in the household. Now, we can continue to unpack our model fit, and we have the mixing in each phase and each setting. So we can track the infections acquired in each setting. So we do this by adding additional compartments to the ODE, and then we can solve the ODE with this mixing profile. So we add up the inflows of the total infected. So in the model, this is the exposed and the exposed quarantined. And so we identify the shift from community-acquired infection to household-acquired infection after the interventions. So I would also like to point out that the inset here, this is prior to March 24th, the school contributed least to infection, with the community and workplace and household contributing in this order. However, after March 24th, we see the household dominate. And we can view this same stuff. So we can we can look at this same data with a different graphical representation. So we can look at the cumulative infections by setting and the age class, so further stratify by the age class on the top right. And also we can look at the infections by age class, then stratify by setting. Now, what I'd like to show in this particular slide So we have the infection acquired in the school according to age class. And so I'd like to note here that because of the susceptibility profile, actually most of the infections were among the workforce age group and not the kids. And similarly, the other thing I'd like to note here is the senior age class, so our vulnerable age class. So we have most infections here estimated to occur in the household and the community settings. So as mentioned, we estimated the susceptibility to infection, and this is dependent on age. So in our mathematical model, this is beta I. And so on the, so these numbers here represent the estimated susceptibilities to infection. And I'd like to note that we're using a slightly different approach than other works, but our results are in line with prior studies. So these include both modeling studies and more studies which investigate infector and infectee pairs, so more epi study. And furthermore, the other age-specific parameter that we estimate, the other key one, is the percentage of symptomatic individuals that are diagnosed. And we expect that this is an increase, so this quantity increases by age, because with more severe infection, we're more likely to capture these cases. They're more likely to seek attention. So also the last thing I'd like to note here is that on the bottom right here, we show that so these are called the empirical distributions. So each of the 1,000, so we estimate the model parameters 1,000 times, and we show the histograms for each of these susceptibility to infection. So I just like to note that the estimated susceptibilities are robust to the noise that we introduce in the confirmed case report data. So we identify well the susceptibility to infection. Now, a few caveats to consider. So the case report data may have error, and so we address this with uncertainty analysis. So we assume a Poisson error structure to express uncertainty in the parameters and to capture noise. Also, I'd like to note the testing protocol has been variable in Ontario. So early on in the epidemic, so early or the province had an affinity to test only those with symptoms. And this was later changed as testing capacity was enhanced. So those not presenting symptoms could also receive a test if they felt they were exposed. Now, we also have heterogeneity in location. So Ontario is a large province, and so it's composed of 34 different health units, and these may have different local features. So a key example is that Toronto is one of the health units here, which may have very different features than other areas. So actually modeling these, it may be better to model with higher resolution. So in these regions to get more robust results. And to accurately model transmission in the province, it may be something to consider that healthcare workers in long-term care homes were disproportionately affected. And these comprise a fair portion of the reported cases. So a few caveats. Now, conclusions for this particular study. So in this work, we assess retrospectively the contact shift with the implementation of measures. But we really see that the non-essential workplace closure seemed to have the greatest impact in terms of reducing the contact. So this is a framework for intervention evaluation, and we've noted this. So we can also use this framework proactively. And so it's amenable to weigh different vaccine distribution strategies. So we feature the age structure. This is key. And we can also investigate how to ease restrictions and do various scenario analysis here. So for instance, the rotating workforce, rotating school, different strategies in this line. And another item I'd like to note is that we can provide insights only using case data. So we're using surveillance data and also demographic data such as the age structure of the population. So we can infer the mixing without any prior or without any participant participation. So no survey needs to be conducted here. And the data, including the projections of the contact matrices, are available in many different countries. So 152 countries, including Canada. So here we do the modeling study as well as the more epidemiological study. So finally, I'd like to note a few projects in progress. So in this work, we've shown analysis for Ontario, and we're also working on a comparative analysis between Toronto and the rest of Ontario. And we can look at insights for a more region-specific intervention strategy. And also looking at age-specific immunization program optimization. And items 1 and 2 show the immediate application of our framework. And the sense is that you can address many different research questions when you identify the mixing and you identify the age profile. So the mixing and the susceptibility are key factors. And third, and lastly, just like to note that we're working on web app development so that our projections can be displayed. So we're working frequently to update projections for Ontario and also Toronto with our transmission models. So Professor Wu is a member of several of the expert panels. I'd like to thank these panels and also our support from CIHR. A few of the references from this work. And with that, I'm happy to take any questions, and thank you.
Thank you. Thank you, Kumar. I just want to emphasize that we intentionally designed this presentation to be relatively short, so that we really want to hear feedback and comments and to kind of redirect our focus in the next few weeks. Doc, I just got some messages from the chat that I think you're very good speakers. Thank you. You represent very well of the team.
Actually, before we go on, Jianhong, let's all of us thank Zach for the excellent talk. And I think now, Jianhong, would you like to conduct the Q&A?
I can do it anyway, so I will be biased. I have a question from George. George, do you want to raise a question directly? I think you're asking questions about the variability in size.
Oh, sure. Thank you, Professor Yu. Thank you, Zach. For a nice presentation. Just I want to ask about contact in different community or in different households. So, for example, when you talk about household, so I don't know, for example, if you consider a single family house or an apartment, so there's different variability in size. So did you, for example, consider that uncertainty in terms of variability in order to not to be like to have such maybe, if I can say, bad conclusion in terms of the rate of contact with that specific item, or also which size of community did you consider during the analysis?
Great, so thank you very much for your question and thank you for the kind words. So in terms of the household contact structure, so the way that the household contact matrix was obtained, so here we have panel B is the, or I'm sorry, panel A is the household contact matrix. So the way that this was obtained, so we use data specific to the province of Ontario. So we use the local demographic data to transform the prior results from reference 5 here. And the way that, really the way that these matrices are constructed is you ask, so you perform a survey. So you ask different people about the locations and the age group of the people that they contact. And in this way, specifically to your question, it would be assumed, so there will be people, so individuals which respond to the survey, which are members of normal household settings, and also, they will live in apartment complexes. So we really have a variety of different settings here in terms of the location at which people live. Now, to your second question, so the size of the community here, so we conduct our, if I understand your question well, we conduct our study in the whole province of Ontario. And I'm sorry, I missed the item about the variability. So what was your specific question there, if you don't mind repeating?
Yeah, sure, no problem. So I was saying that, for example, when we talked about contact for household level, so I don't know, for example, which level of household you are talking about. Should be like median with the single family house, or did you consider different? Because, for example, people who live in apartments, and if you consider apartments, or if you consider single family houses, so the size of people who live in there, they are different. So how do you consider this?
Right. So this is an aggregate figure for the household contact mixing. So in fact, there's households with size 1, 2, 3, all the way up to 5 that are included in the study, and greater than 5, of course, too. So we account for this, not explicitly, but it is, so the contact is an aggregate of all of these different structures. And it's a very good question, because the mixing profile in each of these different household structures is different. So we will a household of size 1 will have a different mixing profile than one of size 7. Or size 2 instead of size 1. So size 2, we may have a couple, or a parent and a child. So we have this mixing pattern. And on the other hand, size 7 may be a full family with a grandparent. So we will have a more interlinked structure, which will be more of the way to look at this is actually, we have kids mixing with kids, we have kids mixing with adults. This referred to as a tri-diagonal contact structure, which we actually observe here. So age classes are primarily mixing with their own age classes. And then we have the off diagonals.
So to answer your question, George, so I think you're asking whether you can still further stratify the household by the tuning the type of houses. So this part is exactly what I hope we can discuss this. We have not done that. You need to regroup, aggregate the population, the household in different household types. And this is the same when you are trying to use this kind of stratified population model for reopening. If your reopening strategy is more economic sector stratified rather than by age, then we would need to aggregate the population again by economic sectors. So this is something that we will need really working with the respective stakeholders to see how whether we have the statistic data. And we also need this escalation, de-escalation strategy to be relatively stable so that you can have at least a 2 weeks period of time so that the relative portion of the change of contact tracing, of the contacting can be estimated from the incidence data. So those are all things that I feel that that's exactly we would like to talk. And so we have not done to that fine detail about stratified population in terms of the household types. We did have work on the multi-generation household in Toronto, how to characterize it and potentially to see how the risk of the kids going to school, the impact on the risk of the senior living in the same multi-household, multi-generation household. This work is not published yet. So there is one question from Gabrina about whether there's a paper, the printer is available, and one of the co-authors, Professor Ali Askari, just posted the printed series at SSIM. So yes, printed is available, and the paper I think is going to be online within a couple of days. Now, with that, I want to say again that the whole team is here attending the talk, so any of them can help to answer questions. I have a questions from Quentin Guiti. I hope I pronounced your name right.
Thank you. Well, first of all, thank you for a very interesting talk. I had a rather technical question, actually. I was wondering, how do you identify the transmission rate across all the age classes? And so in particular, I understand that you have a compartmental model that is behind your study. And do you use the alternate differential equation model associated with this compartmental model, or some other kind of strategy?
Right, thank you very much for the question. It's a good question. So we have our mathematical model here, so on our bottom left, and the transmission rate, so the probability of infection on contact is represented by this beta I. So this is introduced as 6 parameters because we have 6 different age classes. And the way we estimate this probability of infection on contact is by fitting this model to the confirmed case data. So in particular, we fit to the cumulative incidence. So we obtain a fit for this model that best fits, and to introduce the to obtain confidence intervals for these parameters, we introduce noise into the case data, into the new reported cases, and re-estimate the model parameters, including these beta i's.
Okay, so just technically about the method you use to fit the data, is it some kind of a nonlinear least square?
Right, so we are using least square. Thank you. Yeah, good question.
Thank you.
So I have another question from a French colleague, Jacques. I don't know if you can raise the question directly. I can read it first. You can follow up. So the question is, have you access to phone contacts between age classes, namely the digital phenotypes?
I'm sorry, could you please repeat the question? I didn't quite catch it.
Jack, can you ask the question direct, or you want to read it again? So the question is from a colleague from France, is about whether we have access to the phone contacts between age classes.
I'm sorry, so am I understanding correctly, the phone contacts?
Yes, between age classes.
I see. Actually, I've not seen any information about the phone contact between age classes, but that's a very interesting point you raise. And I suspect that, yes, I've not seen this. I would not be surprised if it's available though.
I do want to mention that there is a research group led by, I think, by Professor Amy Gurel from Guelph on an intensive survey study about the contact during the social distance escalation phases. I don't know if the results have been published or not, but it really is a very comprehensive survey. There's a question from Steve Patterson about whether the matrices should be symmetric. So there's a question for Zach.
Right, very good question. So the matrices do not need to be symmetric, but at the population scale, they do need to be symmetric. So in particular, so we notice here that the matrices are not completely symmetric because this is the individual level scale. So these matrices represent the contacts of one individual per day. So for instance, 6 to 13 with 6 to 13, this is about, say, one contact per day. But since the ages, or I'm sorry, so since the age classes have different numbers of individuals in them, the matrices will not be exactly symmetric. But there is a population level contact mixing matrix, which represents the total contacts between individuals, which is symmetric. So this is related to the reciprocity condition. So if we rescale the contacts by the number of individuals in the age group size, in the age class size, then in fact, we will obtain something called the extensive scale contact, which will be symmetric. Very good question, very good question.
Great answer, thanks so much.
All right, so let me read out the follow-up question from Jacques, and I think I can answer this question. So can phone contacts be proportional to potential physical contacts? And bracket to be checked. I thought it would be, this is a very complicated question, I think, Jacques, because I think the phone contact they could be inverse proportional as well. And the reason you have phone contact probably because you cannot make physical contact. So I don't know if I answered the question or not, but let me repeat the question. Could phone contacts be proportional to potential physical contacts? We'll continue waiting for Jacques' answer. So now I have next question from Mark Penny. This is a normal question that I will let you, Mark, if you are online, maybe you can ask the question directly. Mark Penny.
Sorry, I was unmuted on my device, but not on the call. Yeah, so this, the original Polymod survey has a particular meaning for what it means by a contact. And it's either a direct physical contact or a short conversation that I think has 3 beats, like you need to say something, the other person needs to respond, and there has to be sort of 3 exchanges of words. And I think we've come to learn that that may be a more restricted notion of contact than is directly relevant for what we know for the spread of COVID. And I wonder if, you know, the sort of under ascertainment of contact numbers might be different in different settings. So for example, maybe most household contacts end up being physical or a conversation, but many workplace contacts or transportation contacts might be of a different type. And I wonder how you think this, this sort of difference between the direct meaning of contact in the base surveys and maybe the more broader notion of risky or infectious contact, how that might possibly influence the results.
I think that's a fantastic question. So you're right. In the original Polymod survey, the contact has a potentially, so it has a very specific definition in order to receive participant survey information. And I think that one contact is not one contact. You're exactly right. So for instance, we have physical contacts, non-physical contacts, indoor, outdoor, you know, and I think that one way to, and also the time, in fact, in the original Polymod data, the time at which the contact lasted,
yes, indeed.
In fact, did not make a difference. So one contact was one contact in Polymod. And
actually, not to interrupt, they do include a time variable in the survey. I think they break down each contact to either be, I think, under 5 minutes, or I think there's 5 different time categories, which wasn't adopted into the Prem research to my knowledge, but at least the original one has it.
Yeah, very good point. So the sense is that this has not been built into the matrices, but in fact, if you have this data, so if we have and the original Polymod data is public, to my knowledge, it's been made public at a resource from the London School. And I would say that we could construct these contact matrices in different locations. And then one way to approach this from, I'm just looking at the mathematical point of view, is that I completely agree that the risk in different settings may be different. And the risk of different contacts may be also unequal. So a contact is not a contact. So one way to address this in a, one potential way that we could address this in a scientific way is with a model of this nature, is to look at different, look at different transmission rates in each setting and further stratified. Now that's one approach. I suspect a better, maybe another way to answer your question would be the, I think there's a vast knowledge from epidemiologists about how these different settings contribute to infection, and these could be, so there's been lots of studies about where infections are coming from, and this could potentially be used to also understand better which contacts contribute how much. So that's a fantastic point, Mark, really.
Yeah, this is a thing that has been partially on my mind, and maybe I'll ask throw a question out generally, which is, you know, the fact that most of us have smartphones now indicate, like maybe alluding to what Jacques was talking about, means that in principle, contact pattern data should be much more accessible than it is. We shouldn't have to rely on a survey carried out in 2005 in Europe to determine what our contact patterns in Canada and mixing matrices look like, at least to an extent. And I wonder, has there been any interest in cooperating with the private sector, namely thinking of people like Apple and Google, who maintain presumably fairly large access to data concerning location, which could then be used to infer contact patterns, if that's even been a discussion or interest or anything along those lines?
So let me take the question, because I want to direct these questions along with the next one from David Earn, because I know his group has been done lots of work in relation to the Google data. Indeed, it will be very much interesting to see how the more contemporary data and contemporary technology data collection can be helpful. And this is not done for this particular study.
Yeah, of course.
Let me move on to David Earn, because David, can you ask the question directly, or you want me to read it?
I can ask the question. So thanks very much, Zach, for a nice presentation. I was just wondering if you could comment on why you choose to fit to cumulative as opposed to interval incidence. What's the motivation for that? And secondly, whether you've tried exploiting hospitalization and or death data in your fits, and if so, what difference that made.
Thank you very much. Yeah, thank you very much for both the kind words and also the good question. So there was no particular motivation in this case for fitting cumulative incidence. So we found with our transmission model that we could obtain a bit better fits in terms of cumulative incidence versus daily. So I believe that more experimentation could be done on this front with how to obtain the best fit with a model with this structure, with the parameters that we're aiming to identify, because we have several different transmission rates, for instance. So there could be more investigation in this area. And also the question about hospitalizations and deaths. I agree with you that this is so no, we've not looked into this, but I think that because of the relationships between the cases and the known and very well studied time delays between the hospitalizations and deaths, that this additional data, so for instance, including one or the other, could be used to obtain stronger results. So I think that's an excellent question. So the time delays are very well known.
So let me follow up two more with two remarks. First of all, in terms, we try to feed to the daily incidence data because the way of looking for the minimization of the parameters is the most classical methodology. It's the mean square. So the stochasticity in the daily incidence make the estimation very time consuming, very difficult. However, if you do a moving window average incidence, then that one will equally works. And this you require actually quite a large window, 1 week window of average. And secondly, about the hospitalization and the deaths, it's the same. So if you use this data, multi-source data to parameterize the model, then you would have to have at least kind of penalized minimization to estimate the parameters. That depends on whether you want to put more weight in terms of the hospitalization and death data, because that are considered to be more reliable. So that's one thing you can do. We discussed about this in an early paper about how to use multi-sources data to have better fit. Dave, I would like you to help to address some of the questions from Mark about the some of the Google data and other more tele.
Oh, okay. I have to run to another meeting, but I'll just say quickly that we have used Apple and Google data to get patterns of mobility, but we've only had aggregated data. I mean, we don't have data on individual contact, which they obviously could provide, but I'm not aware of any public way of getting at that. There may be. We have not accessed such a thing. We've just been using the general mobility patterns that anybody can get that they publish online.
Yeah,
Thank
thanks,
you,
David.
Thank you very much, David.
Okay,
So
thanks a lot.
thank you. I guess that also reminds us the time. So Kumar, can we conclude today's?
I think it's a really interesting presentation, a really interesting discussion as well. On this cell phone issue, there's lots of issues there. What you get in any case is not individuals, but you get device identification or device contacts, and that's a weakness in the data that's generally available. So there's more to be done there. Anyway, thanks again to Zach for a wonderful presentation, and thanks to the audience for informed discussion. Let's thank Zach again for his talk, and all the members in the research group and Jianhong's research group that contributed to this. And we will see all of you again next week. Thanks. Bye.
Thank you all so much.
Bye.